चलो स्टार्ट करो सर, स्टार्ट करते हैं।
Yeah.
Hello,
Good evening, everyone.
good
Can you?
evening. I think there have been a lot of
I know, sir. Very sorry about some technical glitch I was told.
should we go ahead or should we?
We should, sir. Your videos are not coming, sir. Still.
Video is not coming.
Now started, sir. Now started. Good evening, sir. I'll just
Good
start
evening,
off,
good
sir.
evening.
Right, sir. Good evening, everyone. We are very sorry that we had some technical glitch. So we are welcoming you to the second session of Regain Best of EDTA session. Our course director is here, Professor Dr. P.P. Verma, sir. Welcome to you, sir. Thank you very much. And Dr. Vijay Kher is also here. So thanks very much for joining in, or another course director. We have two chairpersons for today's session. We have Dr. Jitendra Kumar, sir, Chairman, Nephrology and Transplantation Medicine at Super Speciality Hospital, Faridabad, and Dr. B.S. Solanki, sir, Director and Head of the Department of Nephrology at Senapram Hospital, New Delhi. So today's topic, there are three topics that will be discussed. One is ANCA Vasculitis Guideline 2024 by Professor Dr. P.P. Verma, sir. Then the second topic, IgA nephropathy, Dr. A.S. Nerula, sir, Director of Nephrology and Transplantation Medicine at Fortis Escort Hospital. And topic three, how far we can go for transplantation by Dr. So without wasting much time, I will hand over the session to Dr. P.P. Verma, sir, to take it forward. Sir, over to you, sir.
Thank you very much, Dr. Manjusha. First of all, our apologies for this delay. This is a technical delay. I think we had no control over that. That is a problem of present day technical know-hows. Well, it has already been conveyed. This is the second session of the best of EDTA, and we have got Dr. Sanjeev Gulati was to present as per program, but unfortunately he is unwell. So I have taken the place. I have preponed my talk. So, and we have got very illustrious other members, Professor A.S. Narula, who is a director at Fortis Escorts, and a very renowned and very learned nephrologist, very respected nephrologist. And I don't have to tell you about Professor Kher, who is a co-director and who is also talking on the transplantation scene, what is new about transplantation, what was discussed. The chairpersons, Dr. Jitendra Kumar and Dr. B.S. Solanki, both are very learned and respected faculty members. Dr. Jitendra Kumar is the owner and director and chairman of Accord Hospital, Faridabad, and Dr. B.S. Solanki is director and head nephrology at Sir Permanent Hospital. I'll be sharing my slides. I hope I am able to. Because of this technical hitch, we could not try anything. I'll share the screen and hope I'm able to do that. Are my slides visible?
Recording in progress. It's visible, sir.
Professor Kher, sir, I have for proceedings. Professor Kher, sir. Is Professor Kher audible? Anyway, if
Sir is there, but I think sir is facing maybe audio issue.
okay, I'll start with it.
Yes.
Well, I'll be talking in the next 20 minutes, and I'll request the other speakers also to stick to 20 minutes so that we can have discussion for next 5 to 10 minutes. I'm talking on 2024 guidelines for ANCA-associated vasculitis. Well, we all know that untreated ANCA vasculitis has over 80% mortality. Cyclophosphamide and rituximab have changed the outcome. However, the relapse rate is still pretty high, almost 70%. The emerging data shows that complement plays an important role in the pathogenesis of ANCA vasculitis. Now, the guidelines for treatment of ANCA vasculitis were laid in 2021, but two trials which appear later, which is Paxivas and Advocate trial, they forced the KDIGO to lay down fresh guidelines. I'll go to the background for 4 or 5 minutes and then come to the guidelines. When we talk of ANCA-associated vasculitis, by and large, we are talking about three disorders: microscopic polyangiitis, where the kidney involvement is usually 80% and plus. We have got granulomatosis with polyangiitis, what we used to call Wegener's, where the kidney involvement is almost 70 to 100%, and eosinophilic GPA, where the involvement is 40%. There are many antigens in the cytoplasm, but what we classically talk of is myeloperoxidase, that is MPO, and proteinase 3, or PR3. There are other antigens also, like many peptides, mucin, plasminogen, peroxidase, and pentraxin, but that is all right. Important ones are these two. Just one slide about the pathogenesis or pathophysiology, what really happens. Because whenever a person is developing ANCA vasculitis, that means there is a loss of tolerance. And these neutrophils, as you see, they have got these antigens which have to come out. And there's a priming of these antigens. When the ANCA binds here, these antigens come out. And subsequently, you see, if there is a complement C5a activation, that causes the respiratory burst and eventual vasculitis. So I'll go only up to that. Knowing it pretty well, it is the neutrophils which regranulate, which have got antigens. So antigen-antibody complex, the complement is there, and the respiratory burst and the vasculitis. Till 2010, all the trials which appeared, important one, the PEX, the cycloserine, MIPEX, the VGENT, the Cyclopes, they all concentrated on cyclophosphamide and steroids. It is only after 2010 when the trials RAVE, rituximab, Paxivas, and other trials came where the rituximab started getting used. We will talk about just two trials. One is for induction, that is the RAVE trial. Here, the rituximab was compared with cyclophosphamide. So rituximab, 4 doses, almost 500 milligram every week for 4 weeks, was compared with cyclophosphamide 2 milligram per kg body weight per day for remission induction. And a multicentric trial, 197 patient, and what you found that the response rate was similar. However, the patient who relapsed, the response was better with rituximab. The message was rituximab therapy was non-inferior to daily cyclophosphamide for induction in severe ANCA-associated vasculitis, rather was superior in relapsing disease. So this was an important trial which conveyed to us that rituximab is as good and better in relapsing disease. Coming to the maintenance therapy, this trial Vitazerine, so that again a multi-country the trial from 7 countries, 29 center, 170 patient. The comparison was the treatment initially induction was with rituximab and glucocorticoids. So one group was given high-dose steroids for 3 days, other group was given azathioprine. And the comparison was that whether we should give rituximab to these patients as maintenance or we give azathioprine as maintenance. And the answer was the relapse was much less if the rituximab was given vis-a-vis azathioprine. So logically, so this is an important trial which showed that rituximab is a better drug for maintenance rather than azathioprine. Well, this is a 10 reports clubbed together, 7 RCTs, large number of patients, 752. They compared only that vis-a-vis maintenance rituximab or azathioprine or methotrexate or MMF, and the answer was very clear. The major relapse risk was highest if you are giving MMF, methotrexate, and even azathioprine, it was 2.39 times higher than rituximab. Likewise, the relapse-free survival was, if we take rituximab as 1, the hazard ratio was 2, twice in azathioprine, 2.5 times in methotrexate, and 3.5 times with MMF. So again, it is showing that rituximab is a better maintenance therapy. Now, coming to the standard treatment as on today, what we are giving and how we are managing our patient, we give induction either with cyclophosphamide and steroids or with rituximab plus steroids. And plus minus, we give Plex. The maintenance classically is with azathioprine or rituximab for 18 to 24 months. This is the standard of therapy today. A word about Plex, because you have written plus minus Plex. The trial which gave credence to Plex was MIPEX trial. This was a large 7-year study, 28 European countries, biopsy-proven ANCA. And what they did, in one group, they gave IV methylprednisolone for 3 days. In other group, they gave 7 sessions of plasma exchange over 14 days. And what you find that the steroid group versus Plex group, you clearly find that if you say the renal recovery and dialysis independent at 3 months, it was 49% in steroid group and 69% in Plex group. So this study gave importance to Plex, that it should be used and it is better. So that is how it is still going on, that in severe disease, possibly the Plex has got a role. So that is what it is. Now, these are the 2 trials, what we said, the Paxivas trial and the Advocate trial, which appeared after the guidelines were laid, that which forced KDIGO to lay down the fresh guidelines. Now we come to the fresh guidelines, what they are. So first we will go to these trials, 2 trials briefly, and then come to the guidelines. The Paxivas trial, what was that? Paxivas trial conducted in 16 countries with severe ANCA vasculitis. Here, the eGFR was less than 50, or there was history of pulmonary hemorrhage. So 704 patients, they divided into 2 groups, and they studied 2 spectrums, 2 important things. One, whether the plasma exchange gives 7 sessions given were superior, had a better outcome. So they found the first was that there was no benefit of giving plasma exchange in patients with severe ANCA-associated vasculitis. The second part of the study was they gave to one group standard dose of steroids and the other group received reduced or half the dose of steroids. And this is what you find, whether you gave standard dose or you gave half the dose, the response rate was similar. That is very important. That is to be recorded, that low dose steroids are as effective as standard dose steroids. And importantly, logically, if you are using low dose steroid, the severe infections were also less. So that is one study which tilted the balance for new treatment regimen. that low-dose steroid be used. Now, this is what, again, in pictorial, the plasma exchange, no benefit, and standard dose steroid versus reduced dose steroid, the response rate is similar. The second trial, which forced the guidelines to come, this was again Evacopan. Evacopan is a C3, C35A inhibitor. Now, we know terminally that complements the C35 comes, and then, of course, the membrane attack complex comes. Now, this is an inhibitor of C35A. 143 centers, 331 patient receives cyclophosphamide or rituximab. And what you find, the remission at 26 weeks was similar. 70% prednisolone, 72% Evacopan. But the endpoint was the sustained remission at week 52. And you find that this was statistically significant if you are using Evacopan or the complement inhibitor. This is again the same study that the patient were assigned to these two groups. I'll skip that. It only shows Evacopan was not inferior to prednisolone taper with respect to remission at week 26, but superior in sustained remission at week 52. And also, the sub-analysis of the study showed that if you are giving Evacopan, the proteinuria drop was much faster than this is the standard therapy. Red one is the Evacopan therapy. And also, the recovery, there was a greater recovery of renal functions in the Evacopan group vis-a-vis standard steroid group. So this is Evacopan is a superior drug. Now let's come to the guidelines. I just want to convey there are only 4 messages what I want to convey from the new guidelines. The first message, you suspect a person is having vasculitis. Now, if the clinical presentation is compatible with ANCA vasculitis, like suppose you have got a rapidly progressive glomerulonephritis, a patient comes and you have got no suspicion of secondary vasculitis, and patient has either MPO positive or ANCA positive. If ANCA positive, clinical profile is compatible, you don't suspect any secondary vasculitis, you start the treatment immediately. And if the clinical presentation is compatible, however, PR3 or EMPA is negative, then possibly there is no biopsy contraindication. Go for biopsy and then start. But if ANCA is positive, don't wait for the biopsy. Biopsy can be done later, or if it is done, the report can come later. Start the treatment. The delay in treatment will only increase the incidence of end-stage renal disease. So that is message 1. If clinical profile, I repeat, is compatible and NPO-PR3 is positive, start treatment before biopsy report is available. Now, what treatment to be started? This is the second message. You assess the disease. If the person has got life-threatening disease, suppose a person is dialysis dependent, creatinine 6, 7, 8, the kidney is compromised, life-threatening kidney disease. Other is no organ threatening, you find creatinine is 2 or 2.5 or something. So if it is a life-threatening disease, our creatinine is generally over 3.5, 4. What should we do? Combine all. Give rituximab plus cyclophosphamide plus steroids and consider plasma exchange. And if there is no life-threatening disease, you can start either rituximab or cyclophosphamide with steroids or Evacopan. So the message 2 is, in patients presenting with markedly reduced or rapidly declining glomerular filtration rate, creatinine more than 4 and organ failure, combination of rituximab and cyclophosphamide should be considered. So this is message 2. Now, why this has been? There are two studies I'll bring to you. So one study is from Hammersmith Hospital, London. That is what they have done. They studied 64 patients with creatinine almost 7, dialysis dependent, half of them, lung hemorrhage in half, and Brigham vascular score was 19, pretty high. They gave cyclophosphamide, rituximab, oral prednisolone, and plasma exchange. And what they found, that 94% achieved disease remission by 6 months. And 67% of patients recovered from dialysis and became dialysis independent. In long term also, the end stage kidney disease free survival was almost 70% and 87% was relapse free. So fantastic result. So that is what is prompting the KDIGO to take this step. And it is, again, a second study. This is from Mass General Hospital. And what you are finding, that they were having 129 patients, 31% received Plex. And by month 5, whether it was MPO positive or it was PR3 positive, in both of them, if you see the response, by month 5, 84% had complete remission by this combination therapy. So that is an important point. So if you look at the induction regime, I will not go. So these are the trial, MIPEX, rituximab, Paxivas, now Imperial College, that is Hammersmith, Gulati, and all this they have given, and Mass General Hospital, what I told you. So that is a combination therapy has come in for severe disease. Now, who should be given rituximab and who should be given cyclophosphamide, and what is the benefit of combination? So the benefit of combination logically is faster treatment effect, steroid sparing, cyclophosphamide sparing, less dose, and more effective than either of them alone. When you want to give rituximab, children, premenopausal, frail old adult, steroid sparing, and PR3 disease. Cyclophosphamide is preferred when difficult to access rituximab or if it is a severe disease. In severe disease, mind you, cyclophosphamide is possibly better than rituximab, or you give a combination. Now, keep in mind that if you are giving rituximab, you are bound to see secondary immunodeficiency, and it is recommended that every 6 monthly at least you should do IgG level. And if the level is moderate to severely deficient, that is the time they should be given immunoglobulin. Now, the next recommendation comes that stop immunosuppressives if the patient is on dialysis for 3 months, which is an old one. Evacopan may be used as an alternative to steroids. Patient with increased risk of glucocorticosis, suppose the person has got osteoporosis, they are likely to receive the best benefit from Evacopan. And consider plasma exchange, as I mentioned, if there's a pulmonary hemorrhage or dialysis requiring patient. So who gets maximum benefit from Evacopan? Patient in whom steroids are contraindicated, patient with refractory disease, and patient with low GFR. They get the maximum benefit. The next message was from Paxivas trial. As I mentioned, low-dose steroid was non-inferior to standard dose. They look at the dose, what they are giving. First week, 60 milligram, second week, 30 milligram, third week, 25 milligram, and gradually you find by week 12 or 13, you come to 5 milligram. That is what is recommended now, that taper the dose fast. So that is the third message. One needs to avoid high-dose steroid since low-dose steroids are equally effective. So mind you, if you are giving steroids first week 60 milligram, next week only, I'm taking this because it's the normal weight of our patients. Next week it is 30. And the third, fourth week, keep decreasing the dose. That is an important message from present guidelines. And lastly, the fourth message is, how do you maintain remission? So maintenance, either you continue rituximab or switch to azathioprine and taper glucocorticoids. For how long? The duration is longer. Maintenance therapy needs to be continued for longer period, generally 3 to 4 years, rather than 18 months to 2 years, what we were giving. If you want, the relapse should not occur. Who should be given rituximab maintenance? Relapsing disease, if it is PR3, glucocorticoid sparing, azathioprine allergy. And who deserves azathioprine? Logically, if there is a IgG level is low, or there is a limited availability of rituximab, whatever the cost factor, today it is not very expensive. So recommendations is maintenance immunosuppressive therapy should be given to most patients. Duration 18 months to 4 years. And if you are considering MMF or methotrexate, keep in mind methotrexate should not be used if the GFR is less than 60, and know that they are less effective than azathioprine. I'll not go into the dose. Can you predict relapse? Yes. The patient who has got PR3 positive, higher serum creatinine, extensive disease, ENT lesions, history of relapse, ANCA positive at the end of the induction, rise in ANCA during treatment, lower dose of cyclophosphamide, they are the people who can go into relapse. So relapse rate, if you see in all the trials, is anything from 30 to 80, 90%. In relapsing or refractory disease, you have to reintroduce rituximab. And if you have given rituximab before, go to cyclophosphamide and vice versa. In the setting of diffuse alveolar bleeding, plasma exchange can be considered. I'll stop here because the guidelines finish here. Just to mention, outcome of AAV has improved. And today the remission rate is over 90%. In life-threatening disease, a combination of cyclophosphamide and rituximab is preferred choice with plasma exchange. For severe disease, rituximab is not superior to cyclophosphamide. There, cyclophosphamide takes an edge. Rituximab is better choice for maintenance therapy, and it should be given for 2 to 4 years. Lastly, there appears to be an important role of alternative pathway of complement in pathogenesis, and Evacopan is better than steroids. I stop here. Any questions? I am available.
Hello, can you hear me, General Nehru?
I can hear you, sir.
Yes. So thank you very much for that exceptional. I got disconnected in between. I had to change my equipment as well. So I don't know. This seems to be a overall internet connectivity issues coming up. So it is filtering on to. So any questions or comments? Do we have the chairpersons today? I don't know.
Sir, good evening.
Jitendra, yes,
Solanki.
Dr.
Yes.
Solanki,
Sir,
good to see you.
comprehensive and insightful presentation, sir. My question is, sir, these all are guidelines for patient when patient is presented predominantly with the renal manifestation.
Yeah.
What if patient is presented with predominantly neurological symptoms? Recently, I have encountered a 50+ female presented with the severe neurological manifestation up to the level of paraparesis with the stable serum creatinine of 2.2 and non-oligouric pattern with the positive for ANCA both C and T. Still, we did the kidney biopsy which suggests cellular crescent, but then the creatinine was always stable. We started her on endoxone and the steroid. She responded well. Her neurological symptom improved. So, is there any separate guidelines?
The question is the answer to that. Very good question, Professor Solanki. But the answer is very clear. It is not only kidney. If there is involvement of any systemic disease or organ damage, severe organ damage, you treat it as a combination therapy. That is the best. The kidney lesion, we are nephrologists, so we are talking about kidney lesion also. As you rightly said, the system involvement can be diffuse pulmonary hemorrhage only. The system involvement can be neurological. But if it is an organ failure and severe organ damage, a combination therapy for induction is recommended today. And rituximab, what we are trying to continue, they are continuing practically the same dose, like 6 months, 12 months or so. They are continuing the same dose as the induction, what you are giving 1 gram repeatedly. There was a question in the chat box, how much rituximab maintenance dose be given? So maintenance dose is the same as that. The steroids have come down, but rituximab dose is there. That is why every 6 months you have to do immunoglobulin profile that the person is not deficient in it.
Anyone else? Is Dr. Jitendra there as well? He was supposed to be coming. Jitendra. So, General Verma, are you taking the other one as well?
Hello, Dr. Jitendra is there?
No, I don't see.
No, I think then if there are no questions, I'll stop here.
And then General Narula will take over.
Yeah. Am I audible?
You're
Yes,
audible.
you are. You are audible and visible very, very clearly.
Okay,
Sir.
fine. So I'll just put my slides in full screen. Let me see. PP says it runs. So let me see. Yeah, my slides are visible now.
Not yet.
Now?
No,
Not
No.
yet.
you
So
press the share screen
yeah, that's what I've been
and
trying.
then put on your desktop, click on your desktop.
Yeah, just a moment. So I'm in my Zoom app and
Yes.
yeah, so somebody else can do it. There's some problem I'm never able to show. I had sent it to Deepak. Deepak, will someone show it? Share screen. It somehow it never seems to come in my this thing. Is Deepak there? I'll just give him a call.
I think you try once more, Dr.
So
Narula.
I should go off and come in. Yeah, one moment.
Yeah.
Just switch it off.
I've got share screen. I go to desktop.
No, first you go to your computer.
Yeah, go to desktop and get your
open
slides
your
on the
slide
desktop.
presentation.
Yeah,
Open your
my
slide
slides are on
presentation.
the desktop. Open
Now
system.
minimize them. Minimize them.
One moment. Open system preferences. No. Just give me another minute. So I go to my minimize my slides, you said, no?
Yeah,
Yes,
minimize your presentation.
Okay, just give me a minute. Yeah, I've minimized the presentation.
Now share the
Now share the screen.
Yeah, so let me.
Now your slides will pop up and
Okay,
click
now
on this.
Sharing my screen.
Yeah, now press on the desktop.
Yeah, so it says allow Zoom to share your screen.
Yes.
So I should say share. No, somehow it doesn't come with me anytime. I don't know why. There's something wrong. It keeps on asking for passwords and everything. Yeah, I had sent it to Deepak actually, my slides. If I send it to you, PP, can you show it?
You send, I think what we will do, so you send the slides to me.
Yeah.
I'll show it.
That's what I said.
It will take some time.
So let Dr. Kher.
Meanwhile, I'll request Dr. Kher.
Now, unfortunately, since I've changed my laptop,
So PP, I'm just sending you on WhatsApp the slides.
Okay.
So I have also sent slides to, because I had to switch off my laptop because something went wrong in that. So I had opened my slides there and everything was working, looking like, but I had to suddenly switch it off because it wasn't getting connected well.
No, I'm just sending it to PP.
So I have also sent it to Deepak, and I don't know whether Deepak can run it.
Even I had sent it to Deepak in the afternoon because I know there's a problem.
Let me
Okay. Should I send it to your WhatsApp, Dr. Verma?
No, send it to my email.
You've got a very funny email at Rediff. You've got an email.
Yeah, Verma PP 123.
Yeah, VARMA Verma PP
123.
Yeah, one moment. 123.
@rediffmail.com.
Yeah, at the rate of Rediff with a double F.
Yeah.
Okay, there it goes. It's been sent to you. Have you got it?
Let me see, just a minute.
Yeah, I could hear your ping.
Not so far.
Okay, let me try again.
No,
Why?
your slides have not come.
Okay, I'm sending it again. No issue. It'll take another minute. I'm just sending it again.
VARMA.
या VARMA. अरे भैया आपका इतना पढ़ लिया हमने जो आपने भेजा है. Yeah, EDTA copy. No, not key. Cancel PPT. Just give me a minute. Yeah, this is the one. Send. It's loading. It's a big slide. Okay, here it goes. Message has been sent. Now you can see.
Yeah.
You got it?
Yeah, I think I have got it.
Yeah. EDTA copy PPT.
I know that. Let me see if it opens. I hope you are not sharing the screen. That is off.
No, mine is off.
वर्मा जी मेरा स्क्रीन और वो सारा ही इन्होंने ऑफ किया हुआ है. आई थिंक somebody has to add me as a panelist. I don't know. कुछ किया हुआ है इन्होंने.
Narula, your
Yeah.
slides have come.
Okay. Should I start?
Please.
Dr. Kher?
Please.
Yeah. So
Yes,
at
yes.
the outset, Dr. Verma, Dr. Kher, thank you for this opportunity. It's been a learning experience for me. So whenever you look at IgA nephropathy, there are a few questions which popped up when I was preparing this presentation. That is it really benign? Has the pathogenesis changed? Are there any validated biomarkers? What is the role of kidney biopsy in guiding therapy? We know that we require a multi-pronged therapy. Should it be one step at a time, or can we take multiple steps at one time? From scarcity to plenty, what has changed? Why so many trials are coming up on IgA nephropathy? The targeted release budesonide that we use in India, are we doing it right? Why did the initial GFR go when in the Neficon or the Nefigard trial? Is there a role for repeated courses of immunosuppressants and maintenance therapy like Dr. Verma mentioned for ANCA-vasculitis? When you have isolated non-visible hematuria, should you treat? And what are the surrogate markers? So I was looking for these answers when I was making this presentation. Can I have the next slide, PP? Yeah, so there were 4 industry-sponsored symposiums which were held in the EDTA with about 10 to 12 speakers. So I tried to extract the juice which I'm going to present now. Can I have the next? So yes, IgA nephropathy, we all know, is the most common primary glomerulonephritis globally, and there's a geographical variation in its incidence, with about 50% of people developing kidney failure during their lifetime. Can I have the next? So when you look at the UK National Registry of Kidney Diseases, or the RADAR cohort, they found that IgA nephropathy is one of the major risk factors for kidney failure in young adults. As seen in this green line over here, in young adults, it is one of the major risk factors for kidney failure, and there are no biomarkers. That is the missing piece in IgA nephropathy. Unlike ANCA vasculitis, where we know about the biomarkers, in IgN, there are no biomarkers. Next, please. So they looked at the survival curves, that is from the time of onset to kidney failure in the first slide on the left, in adults and in children. And they found that 50% of adults, 75% of adults and 50% of children reach end-stage kidney disease in about 20 years of time. And when they looked at these survival curves on the right, from the as per the age diagnosis, now look at the age that we commonly see in the green, that is between 16 to 30 years, they found that during the lifetime of an individual, 95% of patients develop end-stage kidney disease. So this disease is certainly not benign. So when they looked at, can proteinuria predict the onset of kidney disease? See in the yellow line, those with most severe degrees of proteinuria had more chances of developing renal failure vis-a-vis those with proteinuria, which today we were considering normal, that is less than 0.5 gram, thereby showing that any amount of proteinuria is bad in IgA nephropathy. There is no level of safe proteinuria. And in this cohort, they looked at how much should the GFR drop from the time of diagnosis so that the individual does not reach renal failure or end-stage kidney disease. Now, in the British population, the average life expectancy is about 70 to 80 years. So they found that in their cohort, if you drop the GFR decline to less than 1 ml here in these orange boxes, only about 40% of people will go on to end-stage kidney disease. But where it is around 2 to 3, you find that almost 100% kidney disease. Can I have the next? So 3 things this cohort showed. One was that the disease is not benign. 2, the disease is progressive. There is a link between proteinuria and the disease, and there is a link between eGFR and progression to end-stage kidney disease. Now, they looked at the pathogenesis. Now, in this presentation, multiple people looked at pathogenesis in a different way, and this was the best I found, that we know in IgA nephropathy, there is an aberrant mucosal immune response, whether it be to an infection or to a food antigen, and this antigen is taken up by the dendritic cells in the mucosa, and in the presence of cofactors like BAFF and APRIL, in a T cell independent manner and a T cell dependent manner, they stimulate the B cells to produce the galactose deficient IgA plasma cells. And these IgA plasma cells, when they reach the circulation, this is hit 1. When in response to this galactose deficient plasma cells, you have production of antibodies, that is hit 2. And when these go on to form the immune complexes, that is hit 3. And when they get deposited in the kidney, that is hit 4. So ample opportunities to treat patients. Can I have that? So to put it in a better way, we have 4 hits, hit 1, hit 2, hit 3, hit 4. And based on these hits, we have 3 main types of therapy which have evolved. That is the immune modulators, the hemodynamic approach, and the anti-inflammatory drugs. What do these do when they reach the mesangium, these immune complexes? They cause glomerular and endothelial damage, which manifests as proteinuria, hematuria, loss of kidney function, and eventually progress on to glomerulosclerosis and hypertension. Next, please. And then they've said that now complement activation plays a major role in the inflammation that we see in IgA nephropathy, leading to the development of anti-complement drugs like what General Verma said, avacopan. Can I have the next? So how do you put everything into one picture as far as histology goes? Now look at this. You have aberrant immune complexes. When these immune complexes get deposited in the kidney, in the histology, you get the M score, the E score, and the crescents when the inflammation is uncontrolled. And when these immune complexes are filtered, you get podocyte injury and tubulointerstitial fibrosis. Complement activation seems to be playing the terminal pathway role in IgA nephropathy. Next, please. So in this group of slides, what they tried to show was the hit hypothesis and how we can target the hit hypothesis at various levels. When you look at the biomarkers, what are the simple biomarkers in IgA nephropathy? So the presence of aberrant IgA1, the presence of hematuria, presence of proteinuria, and drop in eGFR. 4 biomarkers. Unfortunately, none of them are validated for clinical practice. Can I have the next? But there are experimental evidence to show that in people with IgA nephropathy compared to controls, there are increased levels of galactose deficient IgA1, and the presence of immune complexes, as you see on the right, correlates with the presence of proteinuria. Next, please. The second biomarker is hematuria. There is no randomized controlled trial, but small studies have shown, look at H plus and H minus on both sides. Whenever there is H plus, there is increased risk of developing a 50% reduction of renal function or progressing to renal failure. Next, please. When you look at proteinuria, any amount of proteinuria is bad. Whether it is less than a gram or more than 3 grams, they are bad. The only thing is that as proteinuria increases, the risk of developing end-stage kidney disease increases. And this is what led to change in the guidelines of our KDIGO between 21 and 24. If you remember, 21 said more than a gram treat. In 24, now they say more than 0.5 gram you must treat. Can I have the next? Now, what is the impact of histology? Can histology be used as a biomarker? Again, no validated experience, but they found that depending on the histology, you could predict who are going to respond to steroids and who are not going to respond to steroids. Next slide, please. And now the histology has been incorporated into the prediction tool for ESRD. Next, please. Based on this, there is a RCT which has been visualized and which would start soon, in which they would be looking at the active renal lesions, the chronic renal lesions, the effect of steroids in both to see their effect. But I suppose we have to wait for a few more years to see if histological data can predict the response to therapy. As of now, it is the clinical data which you use to choose your therapy. Now, what is the goals of therapy? Can I have the next, please? So the goal, if I was asked the goal, I would say the goal would be reduce the immune complexes, reduce hematuria, reduce proteinuria, stabilize eGFR. This should be the goal of all therapy in IgA nephropathy. Next, please. For that, we've got to understand this chart. So to reduce first the immune complexes and the deposition, we must understand that IgA is actually 2 diseases which are clubbed into one, as seen in this. in the early part of IgA nephropathy, you have a disease-specific immune-mediated nephron loss, in which autoimmunity is playing a major role.
Nice.
In the later part of IgA, it is a generic response to nephron loss which is playing a role. In other words, if you use only conservative therapy in the early stages of IgA, you're losing the battle. And if you use immunosuppression in the late stages of IgA, you are harming the patient, thereby giving us a ground where both can be used. Yeah, it's all right. Next, please. That if the aim is to save nephrons, we should use both therapies concomitantly. And depending on which stage of IgA you pick up the patient, one could be more better or more severe than the other. Next, please. So in this group of talks, they said that this is how we should be approaching IgA nephropathy. I just bring you to the center. It says that it should be addressed simultaneously. That is, looking at the drivers of immunity or drivers of loss versus the generic causes of loss should be looked at and treated simultaneously. So how do you reduce the pathogenic IgNA? By using targeted corticosteroids, by reducing the glomerular inflammation. And how do you reduce the generic related loss of GFR or nephron loss? By using SGLT2 inhibitors, RAS inhibitors, and now the dual endothelin angiotensin receptor blockers. The blocks in green are the ones which have been approved by FDA, while the others are still under various stages of trial. Can I have the next? So can I have the next, please? Now, if you look at this, a classic case that we see all the time. With the GFR mils passing about 2.5 grams of protein, blood pressure is not bad on 130/90. The score is M1, S1, T1, and maybe an odd crescent. The patient is on candesartan 16 milligrams, which is increased to 32 milligrams, seeing this picture, and dapagliflozin has been added. 6 months down the line, BP is good, but look at the GFR, it has dropped. So that means we have failed to control the progression of the disease by using these non-specific therapies to control proteinuria. Can I have the next? So this is what even our 2024 KDIGO guideline says. When you get an IgA dominant glomerulonephritis, consider secondary causes. You think it is idiopathic, you score the kidney biopsy, enter into an international tool to predict the prognosis. And very important, this tool does not guide therapy. It only guides the prognosis of the patient. And then if you think of using an immunomodulated therapy, you must enter the patient in a clinical trial. Next, please. So when they first published, looking at this case, the first thing that they published was that let's see what support we can give our patients. Stringent good blood pressure control, which our patient had, sodium restriction, our patient had, ACE/ARBs, our patient had, SGLT2, our patient had, lifestyle modification, our patient had. And this is where they started saying that probably sparsentan is a better drug to give than an ACE or an ARB in the control of proteinuria. But when this was published, that time sparsentan had not received the FDA approval. And when do you go from supportive care to clinical trial or to steroids when the proteinuria, despite this therapy, is more than 0.75 gram? But now we know that although this was published in 23, it is outdated because now we have seen that even small amounts of proteinuria lead to progression of kidney disease and hence should be treated. Can I have the next, please? So if this was the lady, she was here at this curve, passing about 2 grams of proteinuria. We were expecting her to go to kidney failure in 5 years, despite being under the care of a nephrologist. So there's something wrong in our previous concept that we must give a trial of 3 to 4 months before we jump into immunosuppression. Next, please. So when you look at, does lowering of proteinuria alone reduce the risk? Let's move from the yellow lines to the purple lines. Now let's look here. Let's come down here, that despite an 80% decrease, when you move from yellow to green or to purple, despite an 80%, yeah, that's the last one. Despite the 80% decrease, the eGFR slopes still fall by about 2.5 mLs per minute. That means even at low proteinuria, the kidney disease is progressing. So we need to target IgN much earlier in the cascade. Next, please. So what does KDIGO say? He says, target them moment their proteinuria crosses 500 milligram and not 1 gram, as was mentioned in the 2021 guidelines. Next, please. Now look at the next important thing, that the treatment goal should be to reduce the kidney function loss to less than 1 ml per minute per year. And the goal should be to bring down proteinuria to less than 0.3 gram or equivalent per day. Next, please. Now look at the DAPA-CKD trial. So much was spoken about 2-3 years ago about DAPA-CKD. Yeah, DAPA-CKD did reduce protein. It did seem to improve renal function. But look what happened. But still people continued to lose renal function despite being on DAPA and despite being on ACE inhibitors. That means we needed something better. We were not targeting IgA at its origin. Next, please. So what did KDIGO say? Forget the first two. The last one says that when we use DAPA in our population of IgN, we must remember that the DAPA population were elderly and had a GFR of less than 60. In people with a GFR more than 60, the use of DAPA has not been validated. Can I have the next, please? So what was the initial approach? Like I told you, was the conservative approach, and then sparsentan got approved. Can I have the next, please? Now, what did sparsentan do? Sparsentan blocked the ETA receptor. It reduced the vasoconstriction, reduced the podocyte damage. It reduced tubulointerstitial fibrosis, mesangial proliferation, and inflammatory cell infiltration. Can I have the next? So in this PROTECT trial, which was carried on for a period of about 2 years, they looked at the primary endpoints, that is change in UPCR, and looked at the eGFR slopes. Next, please. The biggest factor, you missed one slide, I think. The biggest factor for, yeah, thank you. The biggest plus point of this trial was it compared sparsentan versus another ARB, that is irbesartan, and look at the significant fall of proteinuria in this sparsentan group. Next, please. And when they looked at the number of people who responded, had complete response, in the green bar, you can see a larger number of patients in sparsentan responded. Next, please. And if you look at the slopes of GFR and you compare the irbesartan, the red, with the sparsentan, it was found that sparsentan people preserved renal function much better than the irbesartan. But we really don't know what happens to these people after 2 years, because sparsentan was used only for 2 years. Some may argue because the blood pressure fell in sparsentan group, that's why they responded. But as you can see, there was no difference in the systolic and diastolic blood pressures. Next, please. So sparsentan was the first drug which the FDA approved. Next, please. We'll just skip this. Now look at the steroid trials. Before they went on to the Nefecon, they looked at all the steroid trials, 2 randomized controlled trials, STOP IgN and testing trial, and 3 retrospective trials. Now, what did they find? They found there was actually no benefit as far as the eGFR decline goes with the use of steroids over a period of 10 years. It reduced proteinuria, but did not add extra renal life to the patient's years. and we were looking to add extra renal life. Next, please. So they came with the Nefecon trial. Next. So when they used 16 milligrams of Nefecon for a period of 9 months, and then they followed up these patients for a period of total 12 months, what did they find? Can I have the next, please? They found that those who had used Nefecon had better preservation of renal function. And this was the answer that I was looking for, which we can discuss if time is there. Why was there a jump in the eGFR in the first 3 months of the Nefecon use? Next, please. And when they looked at proteinuria, there was a significant fall of proteinuria, which continued after stopping the drug at 9 months. And although it rose over the next 24 months, it was significantly less compared to the placebo. So this is the point. It's fair enough. And when they modeled this as to how many years of kidney-free survival you would give your patient, it came to about 12.8 years of kidney-free survival to patients on Nefecon. Next, please. And back, please. Can I have one? Yeah. So can I have go one back? I'm sorry. Yeah. Thank you. So the important point is you use Nefecon for 9 months, and the FDA has now given approval that after using for 9 months, if after 2 years or after 1 year, you find that the patient has relapsed, you can reuse Nefecon in your patients for another 9 months. And this has come into the guideline of KDIGO 2024. Next, please.
Nice.
So when you look at where is Nefecon actually targeting at the payer
Yes.
practice, can I have the next? And I'll just run through the next 3 slides because I'll come to the main crux. Next slide, please. Next, please. Yeah. So back, please. Can you go 1 slide back? 1 slide back, please. Yeah, thank you. So are we doing the right thing in our country by using extended release budesonide rather than Nefecon, which is a targeted release preparation? You use extended release in various intestinal disorders like Crohn's disease, autoimmune hepatitis, where you're targeting various parts of the gut, but you're not targeting selectively the ileum. So therefore, the effect is less, the systemic absorptions are more, and the very purpose of using this particular drug seems to be coming down. Next, please. Can I have the next? And go on to the next, please. Yeah. So next, please. So what have we spoken so far? We've spoken about steroids. We've spoken about sparsentan. We've spoken about Nefecon. But we need to attack at a much earlier stage. Can I have the next one, please? And we need to stop the progression at the stage of BAF and APRIL. We need to stop the production of aberrant plasma cells, which are carrying the galactose deficient IgA. Now, how do we do that? Next, please. Now we know that these 2 chemokines, the BAF and APRIL, they stimulate the B cell and the plasma cell through their respective receptors and the TACI receptors. Next, please. So trials have evolved. Next, please. This is just a continuation of them. So can I have the next, please? So trials have, yeah, stop here. Trials have evolved where atacicept targets these receptors and prevents stimulation of B cells and plasma cells. I'm sure over a period of time we'll come to know what is their effect in IgA nephropathy. This is still a phase 3 trial which is going on. Thank you. Next, please. Next, please. Now, this is an important point. As far as the academics goes, it's over. Now, this is the important point. What has motivated this change? Why is there a flurry of trials in IgA nephropathy? Next, please. So first thing that came was we realized that proteinuria and eGFR slopes can be used to look at the progression of kidney disease. Next, please. So the National Kidney Foundation and the FDA and the EMA got together and said, let's have something known as accelerated approval, Because otherwise, as you see in the left panel, it took many, many years to approve a drug. So that is why if you look at the Nefecon trial, it was for 9 months. And then the phase B continued for another 3 months. And the confirmatory analysis, after confirmatory analysis, will give full approval. That's why sparsentan went up to 24 months before getting the full approval. Next, please. So what do we know about the relationship of proteinuria and eGFR and IgN? Next, please. We know that proteinuria predicts worse kidney disease, worsening of kidney disease. Next, please. We know that when you look at the relationship between treatment effects on 1-year proteinuria and clinical outcomes, adjusted for the EGFR slopes, they were not significant. But when you looked at eGFR slopes, it was found to be significant. In other words, next, please. When you treat, you reduce proteinuria and reduce eGFR slopes. eGFR slope is an independent of proteinuria, predicts clinical outcomes. Proteinuria was not independent of eGFR slopes in predicting clinical outcomes. So the moment we accepted eGFR slopes, more and more companies started jumping into the trial of IgA nephropathy. Next, please. So like I said, these are not mirror images. Look at your Nefecon trial. eGFR slope goes up, but the proteinuria is coming down. Proteinuria improves and goes up, but the eGFR slopes come down at the same range. In other words, you must not only look at proteinuria, but also look at eGFR slopes in deciding autoimmune therapy in our patients. Next. Next, please. So next, please. This was to show you a head-to-head comparison between Nefecon and the use of sparsentan here. It was not really a head-to-head trial, but it was to show that, look at the slopes. They are separate as far as the Nefecon goes and sparsentan goes. But you see, can I have the next slide? But when you look at the effect, which drug was more effective, you found Nefecon was more effective than sparsentan in reducing the progression or slowing the progression of chronic kidney disease. Can I have the next? So we understand that the relationship between proteinuria and GFR is not simple. Reducing proteinuria does not guarantee protection from kidney failure. Treatment strategies must also target the eGFR slopes. Next, please. And this was the pillars of IgN treatment. The conservative treatment, goal 1, goal 2, halting glomerular inflammation, goal 3, reducing production of IgA, goal 4 is the ongoing developing trials targeting IgA at a much earlier stage. And look at what KDIGO has come up with. That will be the last slide, PP. Thanks. That will be the last slide. It says, in all patients, you should target the conservative management and the immune management simultaneously. And they've gone to one step ahead, saying you could probably use Nefecon and systemic glucocorticoids simultaneously. One is to reduce the production of IgA, and other is to reduce the inflammation, provided you don't exceed a particular level of steroids. Thank you very much.
I think, thank you very much, Professor Narula, for very exhaustive and totally up-to-date presentation. I think students have and the listeners have benefited. I think Dr. Solanki is there. Dr. Solanki, please. Yeah.
Can you stop sharing?
Yeah. Any comments from Dr. Solanki?
Sir, excellent presentation, sir. My only question is, sir, usually whenever we try to use steroid in these patients, most of the patients are either pre-diabetic or they landed into the sepsis. So on the one side, guideline itself says that reduction in proteinuria is not a guarantee to the progression of renal disease. So what is your suggestion, sir?
Yeah, so that is where two things happened. One is sparsentan came in to reduce the endothelial inflammation and bring out a reduction in proteinuria, but it did not retard the progression of kidney disease. And that is how Nefecon came in to reduce the exposure to systemic steroids. The other drugs which I mentioned are still in their phase trials, which I'm sure.
Next time, correct. Hello.
Dr. Narula, what at the moment with the available armamentarium, besides the supportive care, what you mentioned, is it time that we give budesonide on one side and give systemic steroids together? Because we
Yeah.
don't have sparsentan at the moment. We don't have any B cell therapies, complement inhibitors. So what is clinically, how do we go about?
So, given the choice, now that we have an FDA approval for repeated use of targeted release budesonide or Nefecon, I think the thing should be to use Nefecon, and when sparsentan comes, combine it with sparsentan. The role of systemic steroids, yes, people have mentioned that you can use, but they've left it very vague. I tried to get this answer in this symposium where people were asking this question repeatedly. And the answer given was we do not have enough evidence to recommend both at the moment. So we recommend one.
General Narula, you hear me?
I can hear you.
Yeah. The question is that Nefecon is not available in our country. Nefigard is not Nefecon. As you yourself said, that extended release tablets don't become targeted release tablets. So if we don't have Nefecon, then don't you think that we should be using small doses of steroids rather than Nefigard, which is not the drug that has been tried? See, we have no trial on Nefigard which shows that it is as effective as Nefecon at this point of time. I don't think there is a trial. Or if you are aware of such a trial, then I would be very interested. So I think that there is another question which I have, and that is that most of our patients, by the time you and I see patients of IgA nephropathy, more than 70 to 80% of patients have GFR less than 30. By the time we biopsy them, there is a lot of chronicity, EDTA of about 30% and more, glomerular sclerosis of about 50 to 60%. So what do you think is the role of immunosuppressive therapy in this advanced stage of disease?
Yeah. So this question was asked to one of the panelists in the symposiums. And she gave a very nice answer. She said, if I find that there is sclerosis, like you said, 20%, 30% sclerosis, but I also find that there are IgA deposits and mesangial proliferation, that means the disease is still active. And her impression was that these people, you should expose them to steroids to prevent the further progression of the kidney disease. But then she went on to amplify her statement by saying that if there is extensive sclerosis and you do not find any active inflammation in your scoring, then I would only give them treatment for chronic kidney disease.
See, there is no good study which has looked at histological scoring system and the outcomes of steroids, unfortunately.
Yeah.
See, all of this has been looked at proteinuria. So correlation of proteinuria to histology is not there. At least I don't find any study which looks at that kind of. So looking at histology and then deciding on treatment sometimes makes it very difficult. But in practical terms, you and I ultimately will decide on if there is extensive sclerosis, like in any other disease, which are also inflammatory and active. You and I decide that there is no worth. It's going to be far more futile to give treatment at that point of time rather than, and it may be harmful also.
Yeah, so she had a point. She said, we see these patients when they are young, 18 to 30 years, and the life expectancy is maybe another 40 years. So in that 40 years, we are trying to give them renal failure-free survival. So that is how in their center, they're using low-dose steroids to cut down on inflammation.
So you would say that in those kind of situations, even if we don't find anything on histology, but you find that there is obviously IgA nephropathy, there will be immunofluorescence is positive. Many times electron microscopy is not done so that you may not see very strong deposits. If you see deposits and you see immunofluorescence which is positive, even though there is an advanced sclerosis, there may be a scope for a trial of steroids, small dose steroids, 30 milligrams or so.
Yes, to slow down the progression of the disease.
So there may.
Yeah, two questions.
The other question I have is, General Verma, is that, see, I think many of us see patients who have mild proteinuria, 400 milligram, 500 milligram, and they have creatinine which has just gone up 1.8, 1. Most of us and don't biopsy many of these. Even we don't know the causes. We many times think that the proteinuria is very, very small. You have brought out that now the proteinuria of about 500 milligrams would be important. So I think we should be, especially if we want to make these diagnoses very early, we should be biopsying all these patients.
The question,
in absence of hematuria or no hematuria.
So that means whatever be the content of proteinuria, once you are suspecting IgA nephropathy, possibly biopsy will be indicated as per you and Dr. Narula. And if there is element of involvement or proliferation or activity, the person should be given possibly systemic steroids if we don't have Nefecon in the market.
So Dr. Verma, the panelists who I was listening to, they had a 20-minute question answers at the end of each symposium.
Yeah.
So all the panelists were uniform in their approach that we should be biopsying them early.
Yeah.
And we should be treating them early because, in fact, John Barrett, I think he said from Leicester that our job is to save nephrons. And if we are there to save nephrons, we must biopsy them early. Otherwise, we are failing in our job.
Yeah.
But what they could not agree on was what to do with isolated microscopic hematuria. Should you biopsy or should you not biopsy? So this was left to debate where two of them said, I would not biopsy isolated microscopic hematuria till there is a trace albuminuria or proteinuria. But one person said, I would biopsy because 50% of his biopsies, he found that there were other causes for microscopic hematuria.
Yeah.
So I think we should biopsy, but not treat at the moment. And
General Narula, there is a question also that
two small questions.
Yes.
One is saying, can we prescribe budesonide 9 milligram extended release tablets for IgA nephropathy patients?
You see, it's this way. The trial was done with 16. But in the Indian setting, they have used 9. They have used 18, depending on what is available in our country. But I'm yet not aware of an RCT which has looked at these two. These are small observational studies, and people say, yes, we have seen a good response. But what happens after you stop? One. Second is look at the systemic absorption. About 40 to 50% is absorbed systematically. So why systemically? So why not give a low dose steroids when you're sure that it's going to act in the glomerular inflammation? How much it acts on the Peyer's patches, I don't know. Nobody knows.
Narula, there is a question in the chat box that if you have a GFR less than 15, biopsy showing more than 50% glomerular sclerosis, would you use Nefecon in that stage?
In eGFR less than 15?
Yeah.
That's
IFTA of 50%. Well, so you want to say nephrons? Why not?
No, you would not use it. It's 15. He's already in renal failure.
I think Dr. Jitendra is also here now. Dr. Jitendra?
Sir, good evening.
Good evening. Your comments or questions on...
कहाँ छुपे रहे आज?
नहीं सर, वो there was some problem with joining the webinar, तो finally वो laptop से किया वो arrange करके.
So that is a question about anything, any comment about IgA nephropathy?
IgA nephropathy में sir, if looking at the general clinical practice scenario, तो अभी जैसे सर ने कहा when GFR is very low when it is late, probably you don't have anything to do. Lekin most of the time, if you just look at the guidelines, तो most of the time if you are early, तब भी लोग बोलते हैं कुछ नहीं करना है. And this is one area where there is a lot of confusion कि वो early disease है तो भी कुछ नहीं करना, late disease है तो भी कुछ नहीं करना. And there are few set of nephrologists who would be overusing immunosuppression, and there would be few set of nephrologists who will be only relying on ARB and ACE inhibitors. So यहाँ पे I do not know, there is not good consensus about what is the right approach.
No, I think what John Narula emphasized today, what I could gather, that we have to hit the disease early, look at the proteinuria, even if it is 0.5 milligram or below, hit out at that. And how to hit, if you have got a targeted therapy, Nefecon, wonderful, that possibly you can hit there also, but also there'll be a place for giving systemic steroids, possibly a combination, which we have not been practicing so far. I thought that's an important message what he conveyed, that possibly there is a place for both targeted therapy as well as systemic steroids if you have to really hit the disease and hit it fast. Don't wait for previous recommendation of 1 gram, even 0.5 gram or so is adequate for you to start therapy. Is that correct, Dr. Narula?
Absolutely. And the role of Sparsentan, whenever it is available to us.
Professor Kher, sir, if you permit,
No.
I'll say we will have your presentation next time.
Yeah. I think it's already
it
too
is
late.
already over 8.
Yeah.
I'm sure many people are very keen to listen to you, but I think they will have to wait for another 6 days. So what we do next week on 9th, instead of 3 presentations, we will have 4 presentations. And we will request everyone to make it.
आपका भी तो था, आपका उसमें था कुछ next में.
Next, I was to present Crescentic. I have presented today.
Okay, so then there were 4 presentations on that day.
Yeah, 4 presentations on that day, and we
Who
make
are the other 3?
Other 3 will be Dr. Gulati will come, Sanjeev Gulati.
Yeah. Okay, yeah.
And 2 more are
2 others. Okay. Yeah. Okay.
Yeah. So
that's okay. That's okay.
I think I can thank Professor Narula, Dr. Jitendra, and Dr. Solanki. I hand over to you for closing session.
Thank you, General Verma. I think despite some technical glitches, which sort of hit us unexpectedly today, and despite a delayed start, I'm sorry for those glitches. But it was wonderful to have 2 diseases, ANCA as well as IgA nephropathy. And both these diseases are not uncommonly seen by nephrologists. And IgA nephropathy, in fact, today we had a pathology session and we were discussing 11 biopsies in that. 4 of them were IgA biopsies. IgA nephropathy. So IgA nephropathy is a very common disease, and unfortunately, as Jitendra said, there has not been a good consensus on the treatment. But I think General Narula did an exceptional job to review the presentations which were done at the EDTA this year, and I think he really brought out that we must diagnose IgA nephropathy early, and we must also treat it early. And I think that's the message which General Verma also concluded, and I think that's very important message. And I think General Narula today, General Verma also talked about crescentic nephritis and summarized the current evidence as well as the combination therapies which we are not as much used to using in this country, but I think in severe disease, and we see severe disease very commonly, but I think combining rituximab with low doses of cyclophosphamide and then using plasmapheresis as an add-on therapy in patients with severe disease or with pulmonary hemorrhage, I think those were very, very important messages which would sort of help us change our approach to these two diseases. These two diseases, one can be devastating acutely, and the other obviously takes some time for it to, unless you see crescentic IgA nephropathy, but otherwise the disease is slow and prolonged, and but causes end-stage kidney disease commonly in these patients. So I think with this, I must say thank both the speakers as well as thank Dr. Jitendra and Dr. Solanki for today's comments as well as chairing this session. And I must thank everyone else and Microlabs for providing us this opportunity to review the best of EDTA this time. And we'll see you next week again. And thank you very much. Good night. Thank you.
Thank you very much.
Thank you.
Bye-bye. Bye-bye.
Bye-bye.